insurance market, although we're really talking about health protection more than health insurance, because we'll be talking about some issues that aren't insurance necessarily. There are other ways of covering health costs or not having coverage at all. My name is Kelly Edmiston. I'm the Policy Research Manager at the Center for Insurance Policy and Research at the NAIC, at the CIPR. And my colleague Gail Brekke is a research scholar at the CIPR. Both of us have our greatest interest in health, although we, at the CIPR, we cover the span of lines of business. And so, I'll work in investment finance or life or climate, whatever have you. But we both have a significant interest in health. So it was fun to kind of put this together, and I'm really glad we have a good crowd. Just before we get into the discussion on complexity of the U.S. healthcare market, I wanted to just say a few words about the CIPR. If you've been to some of our events at this insurance summit, I apologize for any repetition, but I'll make an abbreviated version. We're the research hub, I guess, the primary research center within the NAIC. We're a small but mighty team. Our primary interest is to serve the research needs of the regulators, but also other stakeholders in the insurance industry, including policyholders. We do a lot of what I call policy research, but this is the kind of very practical research that's rigorous in terms of the way it's done, but it's also very applicable and very accessible to people who might not be experts in research. So we spend a lot of time working on projects where we end up with policy reports, but we also are scholars and work on journal articles, as do professors at universities. So we seek also not only to serve the stakeholders in the insurance industry, but also to to expand the state of knowledge in insurance and insurance-related matters. So to begin, I want to talk a little bit about, to put our discussion in context. And when I say put it in this specific way, when I say put in context, I mean, why do we care? Why should we care about this? Why is this important? Well, the U.S. expenditures on healthcare are rather extraordinary compared to expenditures on other items. This chart shows U.S. expenditures on healthcare, the green line, as a share of gross domestic product. As a share of all the combined output of the entire United States over the course of a year. And you can see the dashed line is the trend. It's definitely going upward. The blue line is consumption. And so that takes away all the investment in hospitals and things like that. So this is purely the consumer side use of healthcare services. And we see a similar type of trend, although it seems to be flattening off a little bit. But regardless, it's very substantial, and it's a substantial part of household budgets. Or we can also look at U.S. expenditures on healthcare at a level, and here adjusted for inflation, even in 2022, which is the last date that's available, it was roughly $21,000 per person in expenditures on healthcare in the United States. Interestingly, I can't. I don't have the best eyes, so I have to look at the monitor. But the expenditures on healthcare, if we took the amount of that's spent on health care, which I just gave you, and divided it by average income in the United States, it would be 28%. So that would be 28% of someone's income. But we have to remember that employers often pay a substantial part of that. So most people aren't paying 28% of their income in health care, but it is the case that 28% of the average person's income is going towards consumption of health care. The government provides in the United States doesn't have a purely private market, as you all know. The government is responsible for federal, state, and local for about 1/2 of all health expenditures in the United States. And you can see that private insurance is roughly 1/3. So only 1/3 of the health expenditures are covered by private insurance, which when I first saw these data, I found to be rather remarkable. I'm going to turn this over now to my colleague Gail, who's going to speak to enrollment and eligibility and the uninsured and some other things as well, and then I'll return to talk about some kind of non-insurance coverage of healthcare costs.
Or I can. So since our topic is complexity of the healthcare system and of health insurance, I wanted to start with a big picture look at how people get their coverage. So this graph, we're going to keep in mind, we're going to go to this a little bit later on as well, but I wanted to take kind of a big picture look at how people get their coverage. So the very largest portion is represented by those who get their coverage through an employer-sponsored plan, and that's about 161 million people. And then if we move from left to right, we are going to decreasing size buckets. So the next largest bucket is Medicaid or CHIP, and then Medicare, and it goes on down the line, and the bigger red box in the graph represents the kinds of coverage that the CBO, and that's a consistent definition throughout healthcare, considers to be insured. And we're going to talk a little bit more about some of these other options that provide some level of protection, although they're not considered to be insured. And there's a tremendous amount of effort, as you know, on uninsured and getting more people insured. So one of the things we're going to talk about that is a complexity of the health care market and the health insurance market is how we talk about the uninsured. So again, this biggest red box is those people that are insured according to the CBO definition. And it includes all of those kinds of coverage that are listed on the left-hand side. Those are also the labels on the bottom of the graph, but they're a little bit hard to read. So we have employer-sponsored, Medicaid, Medicare, subsidized ACA, and unsubsidized ACA plans. And then we have some individual coverage, non-ACA, and we could go into details about what all falls into all these smaller buckets. But the CBO report is referenced at the end of our presentation, so if you'd like to look that up, you're certainly, I would encourage you to do so. And then the short-term limited duration plans are interesting because some of them are comprehensive enough that the CBO considers them to be insurance, and some of them are not. So I've actually got the short-term limited duration split into two different buckets, which we're going to talk about. So a portion of that, about 200,000 people, fall into the insured bucket, and then other kinds of coverage makes up the rest of that bigger red box. And also I've got denoted on this graph that there's overlap. So for example, probably the one that comes to mind first is dual eligibles, those people that are signed up for both Medicare and Medicaid. And so the blue bars in the graph actually double count some people in terms of where people get their coverage, because some people have multiple forms of coverage. So the outer red box, if we consider everybody who has some form of what the CBO counts as insurance, that is comprised of about 312 million people out of a total of 336 million. And that's where we come up with our usual number that we see in terms of the portion of the country that is uninsured is about 7.2%. So again, it's a little bit complicated because there's some double counting here. But I did want to start out with just a very broad picture of where do people get their coverage, what are the size of these different buckets. And I would ask you to kind of keep in mind this graph, because in a couple slides we're going to be looking at more detail in some of these smaller pieces. But just try to keep in mind, and we can flip back to it as well, but just the smaller pieces are very small compared to employer-sponsored Medicare and Medicaid. The next thing we want to get into just a little bit is enrollment versus eligibility. So for Medicare, almost everyone eligible is signed up. And from there, the next one to think about is employer-sponsored. The vast majority, about 97% of people who are eligible for an employer-sponsored plan are signed up for it. And one of the areas of interest, I think, and where we have actually a lot of information about plan choice and how people choose is among the about 60% of people that have employer-sponsored, that are eligible for an employer-sponsored plan, actually have more than one choice. So it could be that they work for an employer that has two or more options. It could be a family where both spouses have one option. So on a family basis, there is choice about 60% of the time. So 60% of that 161 million have plan choice. And there is quite a lot of research in that area that we're going to get into in a little bit. And then as far as subsidized ACA plans, and this is 2023 data, so this is, excuse me, this is pretty current. About 76% or more than 3/4 of people eligible for a subsidized ACA plan are enrolled in one. And I did want to provide a little bit more here about eligibility versus enrollment. So there are a few situations in which being eligible for something actually gives you some protection. For example, if you're eligible for Medicaid but not signed up, and something happens where you need to get some care, you actually are eligible to sign up right at that time. And often coverage is retroactive for up to 3 months. So even though we say that those people are uninsured, they really do have protection in the sense that if something happens and they need care, they are able to sign up and get covered right then. And relatedly, perhaps, ACA and employer-sponsored plans have qualifying life events. So if you have a baby or if there's a change in your family in coverage, if someone changes jobs and loses their coverage, for example, then you become eligible to sign up off-cycle. You don't have to wait for the next enrollment period. And so in those senses, you have some level of protection, although it might not kick in quite as quickly as the Medicaid can kick in. So one of the things I'm trying to get to here is that even though we talk about uninsured, I think in a lot of cases we're not very careful with how we talk about that, and there is a lot of complexity to that. And so I think it's worthwhile to understand some of those complexities, some of the timing issues, some of the eligibility issues. And so let's go now to a graph that is focused on the smaller end of the other graph. So the first graph, if you'll remember, the tallest bar is 161 million employer-sponsored coverage. Here the tallest bar is 14 million for subsidized ACA coverage, so just the scale of it, and really zooming in on the smaller right-hand end of the scale. And so here we're just looking at, in the red bar, in the red boxes, we're looking at some things that are not considered insurance by the way CBO looks at them, but they are actually some level of protection. So if we look at inside the blue oval, other types of financial protection. So we have those short-term limited duration plans that aren't considered comprehensive enough to be insurance by the CBO, but they do offer some protection. So that's not the same as being completely without insurance, in my opinion. Health sharing ministries is about 1.7 million people. And I could argue, well, first of all, I could argue that we need more research and a better understanding of what these plans actually cover and how they actually work. But I think a case could be made that many that have health sharing ministry plans are better protected than some that have Affordable Care Act plans, particularly if the deductible is really high. They don't have as much financial protection as what we might like to hope that they would. So I think there's some nuance here in the uninsured numbers that's worth looking into or understanding better. And then I also grouped in here in this left-hand red box, the number who are eligible for Medicaid or CHIP but not signed up. Because again, those folks, if they had some kind of an accident or something happened or a new diagnosis that they needed care, they could actually get care essentially right away. So even though they're not covered, they're not insured, they're actually not, in my opinion, the way I would say it, they're not completely unprotected because they're eligible for Medicaid or CHIP, and so they could sign up and get care right away. So that group of people that have some protection, even though they're not considered uninsured, is about 6.3 million. And then the other two bars in the other red box are people that are eligible for either an ACA plan or an employer-sponsored plan that has an annual enrollment. Unless you have a qualifying life event, then you would have a quicker enrollment. So they have, you could argue or you could talk about they have some sort of protection, but if they have to wait a year, you know, I'm sure you could certainly make a case that they don't have a lot of protection if something happens right away. And that group that has an annual opportunity to enroll, either in an ACA plan or an employer-sponsored plan, is about 9.7 million. So if we look at it this way, so this is a more nuanced way of thinking about the uninsured, we end up with about 10 million that don't have any of those buckets. So they're not insured, they don't have any of these other kinds of protection. And I would argue that this is worth thinking about. The complexity here is worth understanding because the uninsured are not monolithic. So I think this is one important area where we have complexity that we're maybe not paying as much attention to as I would argue that maybe we should be. Moving on to a little bit more about the uninsured. So if we look at using the usual definition of uninsured, there is research that talks about who is uninsured and why. This report is actually from 2019, so it's a little bit older than the other graph that we looked at. But they were asked, people who are uninsured by the CBO definition were asked why they were uninsured. They could give multiple reasons, and by far the biggest reason is affordability. They feel like it's not affordable. Almost 3/4 of people responded that answer. People also said they're not eligible. They said they do not need it or want it, about 21%. And in this report, which is also listed in our references, on our references slide, there's quite a bit more detail that you might be interested in looking at. For example, of those who responded that they're uninsured because they don't need or want coverage, the vast majority of them were young men in good, very good, or excellent health. So perhaps it is a more rational choice for them to be uninsured than someone who is older, has chronic conditions, and that sort of thing. So there's a lot of good information in this report. And then we also want to look just a little bit at what the literature and what the scholarship says about how people choose insurance plans in general. So in this slide, on the left-hand side, I'm illustrating that there is a body of research, and it sort of starts with the research more generally about consumer product purchase decisions. From there, you can narrow it down to the purchase decisions of financial products and how consumers choose financial products. And then from there, you can narrow it down further to how consumers choose insurance products. And for insurance products, the two main drivers of choice are the perception of need for insurance and the perception of affordability. And so this is a general slide. This applies to all types of insurance, and we certainly can bring to mind the earthquake insurance that has been a big project in the CIPR recently, where there have been questions and surveys and experiments based on how it's communicated that there is a need for insurance, and how people even in fault zones that maybe aren't recognized as a high-risk earthquake area like the Boot Heel of Missouri, where there is research needed or there is messaging needed around the perception of need to educate people that there really is a significant risk of earthquake here, maybe more than they realize. And then from there, they would probably move to, once they understand or believe that there's a need for insurance, what's available, what's affordable. So that's the general outline of how insurance choice happens. And then when we look at health plan choice, as I was describing earlier, the 60% of people with employer-sponsored options for health benefits, that adds up to about 100 million people have choice of among 2 or more employer-sponsored health plans. And many of these are self-funded and under ERISA instead of state regulation. But still, we're wanting to understand here in this session the overall complexity. And so in this situation with employer-sponsored benefits, choice is happening at the family level. And so a family, and I'm sure all of you are familiar with this choice as well, and being in a situation where every year in open enrollment, you ask yourself, do I like the choice that I made before? Has something changed with our health? Are we still happy with our doctors? All those kinds of things. So different employees weigh their choices differently depending on their health, their financial situation, some of their preferences and attitudes. And this diagram shows the sets of characteristics that the research has shown are important for plan choice. So there are plan characteristics like who's in network, what kind of benefits, is the deductible high, those kinds of questions. And then there are patient characteristics. So demographics, of course, for example, a younger, healthier family tends to choose a lower cost plan, whereas older people, perhaps with chronic conditions, tend to put more priority on their doctors being in network. So different sorts of people will make different choices and weigh the different characteristics differently. And overall, regardless of whether there's choice, regardless of whether they're looking at employer-sponsored plans or some other types of options, cost is typically the largest factor overall. Not for every single person, but when you look in aggregate, the strongest effect on plan selection overall is choice, rather is cost. So it's going to be premium and out-of-pocket, some combination of that. So then we're going to hand it back to Kelly for talking about choice in ACA plans.
Step up to the podium. Thank you, Gail. Gail had mentioned some information on people's perception of the affordability of insurance and what they think. Do they think they need insurance and these kinds of things? So I just wanted to point out that the CIPR launched a survey. We've already collected the data. It's a nationally representative survey of 3,500 people, which is about financial inclusion. That's generally what the survey is about. but there's a lot of questions about insurance that you don't see in other personal finance surveys and financial inclusion surveys. So hopefully soon we'll be able to come out with some reports that show the responses to that and how people are thinking about insurance generally and across socioeconomic and demographic groups. So I just thought I'd throw a plug in for that survey there. The ACA, under the Affordable Care Act, there's an individual can get on the exchange and find their own health plan, and if their income is below 400% of the federal poverty line, then they would get some kind of subsidy. Of course, the subsidy would be greater the lower their income is. When one gets on the ACA, I resigned from an employer to go and get some additional education in a kind of a new field, and so I didn't have employer-provided insurance for about 4 months, and so I ended up opting for COBRA over ACA. But the reason is that the ACA was really expensive, the ACA insurance, and it is if it's not subsidized. But certainly anyone can get an ACA plan. As you know, they're community rated, and the only thing in some states, smoking matters in age, but otherwise, the rates are consistent. So I don't know if any of you ever put your own information in to see what you would be offered on the ACA. It's kind of interesting if you do that. Even if you have employer-provided insurance, put your information in there and see what your options would be if you were on the individual exchange. And what's most striking to me when I've done that, and then sometimes I've done it also for like families that I made up, is the sheer number of plans that are available. First, you have your tiers, right? Your bronze, your silver and gold. And then on top of that, within each of those tiers, there are several companies, in some states anyway, that will be offering plans. And then each company might offer a set of plans. So you could be looking at potentially 100 different health plans and try to make a choice from that. Now that's complex for sure. So going on with the presentation here, one of the problems with the ACA is with all those various choices that one can make. There's a substantial body of research that shows that most people who get insurance on the marketplace exchange focus primarily on the premiums. So the amount of the premium drives their choices, and so rather than, for example, deductibles, out of pocket annual limits, and so on and so forth. And there's literature that I've read that shows that in a surprising large number of cases, people will buy dominated plans. That is, plans that are better than the plan they got in every respect. And for example, it might have a lower deductible, higher or lower coinsurance, and then or cost sharing, and a lower premium. So that's there's a lot of communication that needs to happen around how you make good choices on insurance. So the tendency to prioritize premiums, that can lead to, as I mentioned, to individuals enrolling in plans that don't adequately meet their healthcare needs or what's affordable for them. While Cost is often cited as the most important factor in decision making. Cost being, for example, the cost to the consumer, the premium. The choice of specific providers and hospitals, that is the network associated with the plan, was less significant for many participants, including a potential disconnect between premium focus and overall health needs. So what that means simply is that people weren't that worried about network issues when they were making their decisions on health insurance plans. There have been nudging strategies. These are either letters or emails that are sent to people who are getting insurance on the exchanges with to educate those consumers, to encourage them to shop for plans. There's a lot of inertia also. I have this plan and I'm just going to stick with it, even though plans can change dramatically from year to year. These nudges will encourage consumers to shop for plans, but they don't often translate into switching behaviors. So the nudges haven't been working very well. There's a lot of inertia, and there's still people who are picking dominated plans. There's a paper in, just as an aside, in behavioral economics where they had people choose from 4 different types of jelly. And then they had another group, this was randomly assigned, they had a choice of buying jelly from 100 different options. And then the people who only had 4 options of jelly were happier with their decision than the people who had 100. Similarly, if you had to choose from 4 cars, you'd feel better about having made the right decision. I mean, it's more likely that you made the best decision among the 4 cars than it would be if you had 100 cars. And I think you can see the same thing with health insurance. Navigating the ACA marketplace presents complexity also. It's quite a challenge for consumers. That when I say navigating the ACA marketplace, that is getting on to the website and whether it's state-based or federal exchange, and putting in all the information, making decisions on plans. I've even noticed that the presentation of the plans can be confusing. The health insurance plans, they have an intricate nature, right? There's all sorts of things to consider, items to consider, the various types of cost sharing, the premiums, the deductibles, the out-of-pocket limits. There's varying levels of health literacy among the population. So there's a lot of the population who have very little health and financial literacy. There are people who are ACA navigators who are available to help those who don't understand navigate the system. But I think there's a mismatch. There's a matching problem there. That is getting these people who may not understand the process with the ACA navigators. Again, our forthcoming information from our survey should show more information about literacy, both financial and health. Sorry, I didn't mean to do that. And then a primary barrier is just there's some jargon and complex language in the plan choices that a lot of people have trouble with. Not surprisingly, many consumers, when they're making this decision, have very levels of high anxiety and uncertainty that can cause them to make choices quickly or make poorer choices. So generally, the message is that we need to have improved communication strategies to address all these challenges around the ACA exchanges. I need to go a little quicker here, but also wanted to mention that the design of the ACA marketplace affects consumer choices. That's mostly what I've talked about already with the jelly jars and that sort of thing. So the way they design the programs doesn't make it any easier. Alternatives to health insurance. Traditional health insurance plan, that's the preferred option for protection from health expenses for a considerable majority of Americans, as Gail just showed you. But there are some unique alternatives to traditional health insurance. One is health cost sharing ministries, and the other is direct primary care. Of course, uninsurance is also an option, right? In terms of health cost sharing ministries, what are they? They're increasingly popular alternative to traditional health insurance. The members traditionally share the same faith, so a lot of these are Christian health ministries, but there's other faiths that have their their cost sharing ministries as well, and they all contribute to a pool of funds to pay medical expenses for members of the cost sharing ministry. Thus, the model, it emphasizes community support and shared responsibility in the sense of we're all, I've mentioned that just simply as a driver of people choosing sharing ministries over insurance, is that is this community aspect that we're helping each other out with this sort of thing in our group, our faith group. And health insurance isn't a community model in the sense that it's a contractual obligation. The health cost sharing ministries, they're not subject to the same requirements as the Affordable Care Act. And at least initially, it seems to me that was a driver of new health cost sharing ministries, that there were some maybe some disagreements with some aspects of the Affordable Care Act. Originally, there was a penalty associated with not having insurance, right? That was enforced by the IRS during the Trump administration. The fee was reduced to zero, which the reason one would do it that way is so it doesn't have to be legislated, right? You just reduce it to zero. But since then, it's been legislated out. But when there was a fee requirement, the people who were in the health cost sharing ministries, even though it's not considered by governments generally to be health insurance, they were not subject to that penalty. There's been tremendous growth in the health cost sharing ministries. In 2010, there were about 200 healthcare. I'm sorry, these are in thousands. So there were about 200,000 people in health cost sharing ministries. 200,000. In 2021, the latest data I have available, it's 1.7 million. So it's considerable growth in the membership in these health cost sharing ministries. They've been around since as long as the 1990s, but the ACA was the real driver in terms of people increasing their membership. Health cost sharing ministries are not regulated as insurance companies. If certain requirements are met, these are mostly administrative. In some states, a lot of the states, the orange states, the health cost sharing ministries are specifically exempt from state insurance regulation. So there's actually laws on the books that say states can't regulate these entities as insurance companies. So there's safe harbor provisions. That's true in 30 states, all the orange states. No state currently treats these cost sharing ministries as insurers. So none of the 50 states do. But there actually have been some courts that have ruled that health cost sharing ministry, the practices constitute the business of insurance. Kind of like if it quacks like a duck and it walks like a duck, it's probably a duck. That's been the message from the courts, but still, in no case does a state regulate them as insurance companies. And again, in these 30 states, there's a specific prohibition against regulating them as insurance companies. one of the primary advantages, of course, is the potential for lower monthly costs. They tend to have much lower premiums compared to traditional or to health insurance. Members often report lower out-of-pocket expenses for routine care as well. So they might not impose the same level of cost-sharing mechanisms, co-payments and co-insurance, or deductibles to the degree that traditional health insurers do. Again, I mentioned the sense of community and shared values that tends to enhance member satisfaction. And ex post moral hazard, there's a nice insurance economics term for you. It typically is less pronounced in healthcare cost sharing ministries. Ex post moral hazard is the tendency of people to spend more on healthcare than is necessary. And the reason is because they're paying a really small fraction of the cost, right? Or zero if they're already past their max out of pocket. So the cost to society is not as high as it's higher than the benefits, but for the individual consumer, they're better off. The benefits are higher than the cost. There's limitations, though. Pre-existing conditions that can be considered under the health cost sharing ministries. They're risk rated, not community rated. So they are able to require exams in some cases. In some cases, it depends on the state, or at various dependencies on health status. One of the ways these might be true is that they might say, okay, if you have kidney disease, you can become a member of their health cost sharing ministry, but only if you haven't had any care in the last year. The essential benefits required in the ACA qualified health plans are not there for health cost sharing ministries. A lot of times there's coverage caps on how much can be spent or covered or reimbursed on a monthly basis, an annual basis, or a lifetime basis. Under the ACA, you can't put a lifetime cap on health insurance. And one of the an additional issue is that when I was looking into these, that is something that would really concern me is that you have to settle up at the end of the year. So if they spent more in coverage than they collected in cost shares, then you've got to settle up. You're going to owe the health ministry a certain amount of money. Again, they generally don't cover all medical expenses, and they don't guarantee medical payment of every medical claim. The other possibility is direct primary care, which really works along with insurance. And the idea there is, Gail's actually quite the expert in this area, but for whatever reason, I'm doing the presentation of it. It's people who make specific arrangements with physicians, generally primary care physicians, and there's no insurance involved. So they just interact. It could even be a concierge type service where they can interact with that physician on an ongoing basis anytime they, not literally call up, but essentially call up and ask the physician questions. And so there's a very different type of relationship, but those tend to work in tandem with traditional health insurance. We've got a lot of references on these slides for when if you're able to get the slides or want to get the slides and look at them, some of these references you might find helpful. We've got about 6 minutes left. Gail and I had a lot to say, I guess.
Yeah.
We're very happy to take questions, any questions that you might have, or at least a couple of them. Yes.
right?
Okay, yeah.
Yes, yes.
I'm, I wasn't, she's asking about the health cost share ministries versus the ACA qualified health plans. I wasn't saying that that was the case, that it was cheaper, but that's why people are pursuing health cost share ministries, because they have the perception that those are cheaper. So that may not have been well worded. I didn't know if you
Yeah,
wanted to add to that.
I think the way I would characterize it, I think that's a good point, is that you weren't necessarily looking at the cost shares versus the ACA. I think we were looking at it from the standpoint of cost shares versus everything else in terms of why people choose a health share. I don't know of any research, although we could certainly do some, that looked at people that were eligible for, say, subsidized ACA that chose a health share instead. I think the research that I've done on health shares and where it's come up in some of my direct primary care research has been situations where people find that the options that they have available to them are very expensive or unsatisfactory in some way, and they go with a health share and they're very satisfied with it because the cost is so much less than anything else that they're eligible for. And I would imagine that the majority, if not all of those people, are not eligible for subsidized ACA. You're right that the health shares don't offer essential health benefits as, you know, a free service for them. And it doesn't include or doesn't use the mechanisms of community rating, and pre-existing conditions are looked at the way we used to look at them before the ACA. And I would say that while that is all true, those are some of the reasons why the health shares are so much less expensive. And we're not talking just a few percent less expensive than, say, some sort of unsubsidized ACA, or even the employee's contribution to an employer plan, perhaps. But the cost to the monthly cost of a health share is very, very affordable, depending on your, it's usually referred to as an unshared amount. It works a little bit like a deductible, but not exactly. But it's people that choose it generally find that it's very affordable. And once you put in the effort to understand that it is different than insurance, and you do understand that you're not buying insurance and you don't have all of the same consumer protections, the people that I've talked to and the people that I've surveyed seem to be generally pretty happy with it. Yeah. Although there are some complaints. There have been, there was a case, I believe it was Trinity Health Share, was shut down in multiple states because they were accused of, and perhaps it was concluded that they did mislead customers and they did misrepresent themselves as insurance. So, you know, certainly there are possibilities of health shares going bankrupt, but there are possibilities of insurers going bankrupt as well. I mean, we have Bright Health, we have Friday Health Plans, we have, you know, it's not, nobody is immune to the financial challenges of trying to do these sorts of things. So I think, you know, part of what I'm trying to bring forward in this session is just, there is a lot of complexity to it, and my suggestion is to look at things broadly and look at all sorts of factors and try to understand all the interplay between things. But it's a very challenging situation with how complex health insurance and health care is.
And you're right, the big cost is there aren't the consumer protections that there are with insurers, so you could be stuck with a big bill and no coverage for that bill. So I agree with you 100%. I know that those consumer protections aren't there. That's the big cost. I mean, you might pay less in some respects, but you lose those consumer protections, essential benefits, community rating, all those things, all the consumer protections under the ACA. And then you're right, preventive care, of course, is covered 100% under the ACA. If I said preventative care, I didn't mean preventative care. I was talking about cost sharing, like copays, rather than not preventative care specifically. So I apologize if I made that association there. So we're happy to stay up here and take more questions.
I do also want to quickly mention that in the poster session on Thursday afternoon, one of my posters is about, it has information on direct primary care and health sharing ministries. So if you're interested in a survey that I did of direct primary care patients and looking at how many choose a health share versus the general population, how many choose a health share, I would encourage you to check that out. And we're happy to take any additional questions.
Yeah,
Come
please
up and talk with
come
us.
up if you'd like to ask us
Thank
any
you.
additional questions.